So here it is, the first part I talked about, the Department of Veterans Affairs. And notice all the personnel that we have across the system here. This is important later when we talk about surgeon capacity. So one thing that we had was we had these secure phones, these scrambled phones, and we had to test them every week to make sure they worked. And I never thought I would use this for a real event, but one day, not long after September 11th, I got a real phone call from my counterpart in Health and Human Services, the director of the National Disaster Medical System. And he said, Dr. Koenig, we found a case of anthrax. You probably remember the first patient, Bob Stevens, in Florida. However, at that time, we did not realize that this was bioterrorism. And in fact, the Secretary of Health and Human Services said, this is an isolated case. There is no terrorism. This is a man who was out on the farm and he got anthrax, and we don't really need to worry about it. Well, of course, that was not correct. So this case study, the Amerithrax attacks, happened following 9/11 when, through the mail, letters were mailed to several news media offices and 2 U.S. senators, and anthrax, a bioterrorism agent, was spread through the mail. This event was not something where it happened and then we went into recovery. Rather, it was an ongoing event, rather like a pandemic, that lasted for several weeks. And yet, with all the resources and everything that happened around this event, only 22 people were directly affected. 5 people died from inhalational anthrax, from breathing in the anthrax spores. 6 people had inhalational anthrax but survived, and 11 people had cutaneous anthrax, or the skin form. So, of course, every life is important, but 22 people in the great scheme of things is not a large number of direct casualties from this major event. But this is not what we usually think about when we think about bioterrorism. The modeling that we had done to prepare for a bioterrorism attack was quite different. The World Health Organization, for example, looks at 50 kilograms of anthrax or tularemia, 2 biological warfare agents, which are made into weapons by the terrorists and released through the air, aerosolized, over an urban population of 5 million people. 250,000 people contract the disease. I know some of you are from the Department of Health. This would be a large number of people to manage. And from anthrax, 100,000 people would die. From tularemia, 19,000 people would die. So not 22 casualties, but a huge number of people was what we had been planning for. And we were not anticipating anthrax being spread through the mail like this. Now, our Centers for Disease Control and Prevention, our CDC, categorizes bioterrorism agents into categories A, B, and C. I'll just mention the category A agents, which are the ones that are of most concern. These are easily disseminated or transmitted from person to person, so it can be disseminated through the air to large numbers of people, high mortality rates, major public health impacts, and might cause social disruption. And one final requirement is we have to know that these agents have been used in the past in biological warfare, as we do for anthrax. So these category A biologic agents can be further subdivided into bacteria, viruses, and toxins, with anthrax being an example of bacteria and smallpox being the example of one of the viruses. So how do we detect bioterrorism? How do we know that it happened? It's possible that a terrorist would say, I've just released anthrax over the football stadium, but more likely it's going to be what we call a covert attack. We won't know perhaps until days later that it happened, when people start presenting to hospitals and clinics with flu-like symptoms. So one way to detect it would be through intelligence. The intelligence community gathering information to know that a terrorist is planning or has executed an attack. Another would be through syndromic surveillance system. Those of you working in public health know that we sometimes look for syndromes, and if we had an increase over the baseline in people presenting with certain types of symptoms, that could indicate that there was some type of outbreak or possibly a bioterrorism attack. But the third way is rather interesting. It could be one of you who's a doctor or a nurse seeing a single patient, and we say the astute clinician, somebody who noticed that this person had something unusual. It was the wrong season, it was the wrong type of rash, etc., and thought maybe this is bioterrorism. So for the anthrax, our first case study, how was the index case, the first patient detected during the Amerithrax attacks in 2001? Does anybody know? In fact, it was a single clinician who detected this case. And here's a picture of a patient with anthrax, and you can see just over a few hours period, the mediastinum is widening, we have respiratory failure at this point, and within 8 hours, the patient is in very, very much distress and severe condition. What is this over on the left? It's a brain at autopsy. And what this shows is hemorrhagic meningitis. About 50% of these patients get hemorrhagic meningitis. And in this case, in Florida, the way we detected it was the CSF, the cerebral spinal fluid, of that patient was sent to the lab and was positive for anthrax. They went back later after finding the meningitis and determined that the patient indeed had inhalational anthrax. And remember, we didn't know it was bioterrorism at first. I got a call on the secure phone, but I was told, we think it's just naturally occurring. Now, here are some examples of cutaneous anthrax. How many of you are frontline clinicians, physicians, and nurses? So if you saw somebody come in with a rash like this, an ulcer and a vesicular ring, this black eschar, black anthrax in Greek is the word for coal, that's why it looks black like that. If you weren't thinking about anthrax, for example, if I told you this was a postal worker in Washington, D.C. in the fall of 2001, you might think anthrax, but otherwise you might think of something more commonly occurring. For example, a spider bite. For example, I'm sure you have this here, as we do in the United States, methicillin-resistant Staph aureus. Can look very similar, right? So you have to have a high index of suspicion and know what's happening, have situational awareness to detect this anthrax so you can treat it. Here's another important example. If we had a single case of smallpox, that would by definition be terrorism. Smallpox has been eradicated worldwide. We should not see any smallpox. So one single patient, by definition, would be terrorism. What would you need to do? Even if it's 3 in the morning, what would you need to do? You would have to get public health authorities involved and also law enforcement. It's a crime if it's terrorism. You have to be able to contact law enforcement. And if you didn't know how to tell whether the person had smallpox, none of us have seen smallpox. Very few people who are still alive have seen smallpox. You might have a patient come in with monkeypox, which looks quite similar to smallpox. And you might say, this is smallpox, it's terrorism. And this has happened. In New York, for example, a hospital closed down because they thought they had a smallpox patient, even though it wasn't. So it can have a major impact on your ability to deliver health care to detect whether it's smallpox or not. Another program we put in place after September 11th is something called the BioWatch program. And what we did is we put these sensors around in major cities to detect biological warfare agents. So once again, that secure phone rang for the second time now, for real. And again, the director of the National Disaster Medical System, my counterpart at Health and Human Services, said, tularemia. Remember, that was on the list of Category A agents, tularemia. We've detected tularemia in Houston, Texas, in the state of Texas. So I said, is it a false positive? And he said, no. It's a true positive. It is tularemia. And I said, are we under a bioterrorist attack? And he said, I don't know. So what happened, I called the medical center director of the VA hospital in Houston. I thought, of course, he knows what's happening in his own community. But in fact, from Washington, I was the first person to tell him that these sensors had detected tularemia. The point is, we put in these very expensive, fancy detection systems, but we didn't have a process in place to manage the data. We didn't know what to do with the results. And all I could tell him was, increase your surveillance for flu-like symptoms, and let's see what's happening. And in fact, it turned out not to be a bioterrorism attack, but again, we did not know at first. So how many casualties resulted from the anthrax attacks? Well, we saw those 22 direct casualties, but when we look at the definition of casualty, there's nothing that's standardized. Does it mean someone who's injured? Does it mean someone who died? I'm a practicing emergency physician. I'd rather have somebody with a treatable injury or illness than somebody who died. If you read the newspaper and it says there's a major earthquake in China and there's 300,000 casualties, you don't know whether they mean people who died or people with treatable injuries and illnesses. Is it somebody, those of you, how many on the DMAT teams here? There's a few people who've responded on the DMAT teams, I'm sure. Mostly what you're doing is primary care, primary health care, not major trauma surgery. So it could be somebody who ran out of diabetes medicine or ran out of high blood pressure medicine, and they're sick because of the disaster, but not really directly injured. So we don't have a good definition. And if everybody dies, suppose a plane crashes at the airport and everybody dies and you're working in the hospital, to you that's not a disaster, even though the public would say it's a plane crash, it's a disaster. Or if everybody is fine on that plane, again, you wouldn't get any patients, so it wouldn't affect you being in the hospital or being in the EMS system or being in the public health department. So to you, it wouldn't be a disaster. Historically, there's been a number of classification systems that we've used. We've looked at numbers of casualties, and what I'm trying to illustrate is none of these is very good. This is historically how we've looked at it, because it doesn't really matter how many casualties there are. It matters whether you have the resources to care for those casualties. Let me give you an example. Big car crash, 5 major trauma patients. You work in a major city and you have trauma surgeons there 24 hours a day. It's pretty much business as usual. Same thing in a very rural place where there's not even a doctor in the hospital. 5 critical patients, you have to activate your disaster or emergency management plan. Same number of casualties, more resources or less resources determines whether it's a disaster. We've also looked at the origin. Is it internal or external to the hospital? Also, this is probably not a very good way to do it. If a typhoon rips through your hospital, it's internal and external at the same time, right? We've also looked at the etiology. And I'm on a mission, and we did this in our textbook of disaster medicine, to eliminate the term natural and man-made from the lexicon. I think it's the effect on the healthcare system that's important, not whether it's a human-made or a natural type of disaster. And here's some examples. Some people might think that anthrax was the first bioterrorism attack in the United States, but in fact, in 1984, in the state of Oregon, a religious cult sprayed salmonella in the salad bars of some local restaurants in an attempt to sway the election. So it was a terrorist intent. They were not successful, but what did the public health people think? They thought, it's a natural outbreak of salmonella. We have this all the time. It wasn't until years later that we realized from the intelligence community that this was a terrorist attack. How about a wildfire? I'm from California. We have a lot of wildfires. People say it's a natural disaster. What if I told you it was started by an arsonist? That certainly sounds human-made. So it's not the etiology, but what does it do to our healthcare system and how do we manage the event that's important? In fact, remember the case study we're talking about of the anthrax letters. We thought for anthrax it would be an aerosolized release over a large population. We wouldn't know that it happened until days later. But yet we knew exactly when it happened. There were envelopes, there were white powder. I had my secretary open my mail for me. And so you knew when it happened, you knew where it happened, you could call the emergency medical services, and it was really managed more like what we would think of as a chemical event, where people knew exactly when and where it happened. I sometimes refer to this as sudden impact defined scene, because you know when it happened and where it happened. So it's one type of way to think about a disaster. We heard in an earlier talk the WHO definition. This is very similar. A condition or situation with or without casualties for which the available resources are inadequate, local resources are overwhelmed, and you need outside resources. When I say it could be without casualties, let me give you an example. Suppose we had a nursing strike in the hospital. Could you continue the business of taking care of patients? You might need to activate your disaster plan to deal with that lack of resource. Even though there weren't any casualties, there's a potential for casualties. Okay, let's move on to the second case study. And let me think about an outbreak. Is that a disaster? We had the good fortune to have a private screening. It's going away. The movie Outbreak. Has anybody seen the movie Outbreak? I think it's only been here a couple of days in Taiwan. A few of you. Pretty scary, wasn't it? So we had a private screening and then a panel discussion. And there's a link in your slides to a newspaper article because a reporter was there during the screening. And one of the things I noticed during the movie is that they had people dying who were co-workers. And I told them, because I knew from your experience in Taiwan, how worrisome that was during the SARS outbreak. So this was very similar to what you see in the film. So I'm sure that you'll be able to identify with that. I would recommend it. It's a very disturbing but interesting film. Some people call it the biggest most expensive public service announcement we've ever had. So leading the government service, in 2004 I moved to my current position as a professor of emergency medicine, and I also work as a consultant to the state of California for emergency preparedness. And the phone rang again. This time it was the governor's office. We were preparing for pandemics, pandemic influenza, and they said, Professor Koenig, how many ventilators do we need to purchase for the state of California to be prepared for pandemic influenza? This is me pulling my hair out. And they said, I think that's the wrong question. Ventilators don't take care of patients. We need people to operate them. We need a system to allocate them. And they said, we know, but the governor wants a number. Why do the politicians want a number? Well, it's something tangible. You can see it. You can touch it. And you can say to the public, we're prepared because we have 1 million doses of Tamiflu or 100,000 N95 respirators. You're nodding, you know what I mean. And so I got together with my colleague and we looked at the CDC modeling and we looked at how many ventilators we already had and came up with a number, 2,400 ventilators. Every time I went to a meeting for the state of California after that, they would rattle off, we're prepared now because we have this, we have that, we have 2,400 ventilators, and I would just think it's almost a number pulled out of thin air. But these are the types of things that we deal with when we're working in a political system. So surge capacity, we'll talk about this in great detail tomorrow. This is just to give you a quick overview now. It's required when patient care needs exceed resources. So again, not the exact number of patients, but we have to look at what type of resources we have. And we heard earlier today that cross-containment strategies have been implemented, and they can be very effective for day-to-day operations. But these type of what we call just-in-time systems, there's no extra antibiotics, there's no extra equipment on the shelves. there's no excess capacity. And so we need some type of a surge system if we have a catastrophic event. Traditionally, for the reasons we just discussed, there's been a big focus on stuff. And the stuff is important, but there's been a lot of purchasing of pharmaceuticals and supplies. There was a lot of money from grants from our federal government after 9/11, and people did things like purchase decontamination equipment, but then we still needed to have training and what we call sustainment training for people to know how to use this equipment. And this is one of my famous lines. Maybe I'll see it on a slide next time I come here. Ventilators don't take care of patients. So, surge system, General Barbish started developing this many, many years ago, and we later refined it to the 3S surge system. The first thing is stuff. It is important to have supplies and equipment. There's no question. The second is staff, the people. When we look at staff, we have to look at behavioral issues. Will people come to work? If I told you we have a smallpox patient in this hospital and you had a baby at home, would you be comfortable coming into the hospital? A certain percentage of people will not be able to come to the hospital or will not be willing to come to the hospital. The other thing is that at healthcare facilities like hospitals, victims can arrive unannounced. They don't necessarily come by ambulance. Friends and family are coming, wanting to know, is my loved one there? Is my loved one okay? There were some interesting anecdotes after 9/11. People were not necessarily where they were supposed to be, and so some people who were supposedly in the World Trade Towers and would have probably been killed, and their spouses would call, honey, are you okay? I'm fine, why? Oh, you weren't at work? No, I'm with my mistress. Okay, not so good. But the good news is I'm still alive. But in any case, friends and family are going to want to know if people are okay. The media, sometimes they are considered the first responders. You can watch the war on television now, right? Everything is on TV immediately. So the media will be there, and you have to be prepared to manage them. And then well-meaning volunteers, as we discussed earlier, might actually get in the way if you don't have a system to manage them. So there's this yin and yang of staff able and willing to report to work versus this convergence of well-meaning volunteers that we have to balance. And then the third S in the 3S concept is structure. And structure has two components. It's a physical place. Now, if your hospital is affected, say the typhoon came through your hospital and you had to evacuate, this might be an alternate care site, like a school or a stadium. And then the very important management infrastructure, the incident command system. A lot of times what's lacking is that coordination system. So stuff, staff, and structure, and we'll talk about this again tomorrow. Now, moving on to the current year, where we've recently formed our Center for Disaster Medical Sciences, we had, of course, this big tragedy in Japan, and the dean calls me and says, I want to send teams to Japan. Again, I'm pulling my hair out. What was I doing? I lived in this very nice beach community, and we, like all good communities, do a hazard vulnerability analysis, and we happen to be in a tsunami hazard zone. And what happened when there was an earthquake in Japan, there was a tsunami coming across the Pacific Ocean to the west coast. In fact, we got hit by a tsunami. It turned out to be a very small one and did no damage. But as you may know, tsunamis are very unpredictable. So we were actually evacuated during this time. And I said to the dean, we need to be sure everything is okay in our own community before we start sending aid to another community, not to mention the logistical issues of doing that. So the Japan event was, of course, very, very complex. Not only the earthquake, but the tsunami. I read some reports of volcanic activity, and of course the radiation exposure. One of my colleagues was telling me that a German team went to Japan, and turned back around and went back to Germany because they couldn't assure the safety of their team members against the radiation. There wasn't enough information to know they would be safe. Then, of course, cultural challenges. We heard a good suggestion about the language barrier is to bring a translator with you. Certainly take that new knowledge back. That's very helpful. The radiation, all kinds of issues happening with that, detecting, screening, how do we communicate to the public and the healthcare providers. This is the current term we've been using, crisis and emergency risk communications, so that they know how to best protect themselves. Triage protocols, mass evacuation. How large is the evacuation zone? That kept sort of changing. Psychosocial interventions, such as psychological first aid. The bottom line is that it was very difficult for any disaster medical assistance teams from other countries to respond, even though there was a clear need and it was such a horrific event. So this is an area where I think we really need to work on for the future. So a summary, we looked at the case studies of the anthrax. Aerosolized release is more what we would expect for bioterrorism rather than this sudden impact defined scene type of event. Issues with surveillance and detection. Still challenges with nomenclature, a lack of a standardized nomenclature for disaster and for even casualty. Then we looked at the pandemic, including the issues of surge capacity, which we'll talk about again tomorrow, the FRIA system of staff, and structure. And finally, the radiation issue, looking at both the actual and the psychological effects of that. And this is a picture of a sunrise from my little beach community that I took. And with that, I say sheshe. And I have one more slide because I've been looking at issues of the effect of social media on disaster and funding issues, and I thought this was a very appropriate to finish up the iPad family. Thank you very much. I'm very, very honored to be here.